The next section, we're going to look at some pharmacokinetic principles, and our objectives are to explain the pharmacokinetic properties of local anesthetics and list the effect of adding vasoconstrictors to local anesthetics. Local anesthetics are different from most drugs used in medicine because they're directly applied at the target site via an injection or topical applications. Systemic absorption and circulation reduces the drug's effect rather than deliver the drug to the intended site of action like other medications. High plasma concentration of the local anesthetics after absorption from the injection site or really unintended intravascular injection are really undesirable and are the origin of their toxicity and our concerns for their toxicity. Peak plasma concentrations achieved are determined by the rate of systemic uptake, by really absorption by local blood flow, and to a lesser extent, the rate of clearance of the local anesthetic. Their uptake is affected by several factors related to the physiochemical properties of the local anesthetic and local tissue blood flow. And the uptake tends to be delayed for local anesthetics with high lipophilicity as well as high protein binding. The local anesthetics are somewhat different in their vasoactivity, but most are vasodilators at clinically relevant concentration, although this effect varies with site of injection. It makes sense because if you block the voltage-gated sodium channels of vascular smooth muscle, they get dilated and the increasing blood flow absorbs the local anesthetics away from their site of action. But keep in mind that this theoretical concept is not always true. Such differences may be clinically important. For example, the lower systemic toxicity of the S enantiomer of ropivacaine compared to the R in part may be because the S has more vasoconstrictive properties. And the variable effect of vasoconstrictors added to local anesthetic solution used for spinal anesthesia is another example. Unlike bupivacaine, tetracaine produces a significant increase in spinal cord blood flow. So, prolongation of spinal anesthesia by epinephrine or other vasoconstrictor is more pronounced when it's added to tetracaine, and tetracaine is a vasodilator, compared to when epinephrine is added to bupivacaine, which is a slight vasoconstrictor. So epinephrine still increases the duration of spinal when it's added to bupivacaine, but the relative increase in time, the relative effect of epinephrine is more significant when it's added to tetracaine. The amino ester local anesthetics are metabolized through hydrolysis, but the amino amide local anesthetics go through hepatic microsomal enzymes. The lungs are also capable of extracting local anesthetics such as lidocaine and bupivacaine from the circulation. And the rate of this metabolism and first pass pulmonary extraction may have a significant influence on toxicity. The relatively rapid hydrolysis of the ester local anesthetics like chloroprocaine makes it less likely to produce sustained plasma concentrations than with other local anesthetics, particularly the amino amides. But keep in mind that the patients with atypical plasma cholinesterase levels may be at increased risk of developing excessive plasma concentration of chloroprocaine or other esters. Hepatic metabolism of lidocaine is rather extensive, and clearance of this local anesthetic from plasma parallels hepatic blood flow. But liver disease or decrease in hepatic blood flow, which can occur with conditions like CHF, congestive heart failure, or even under general anesthesia, can result in a decrease in the rate of metabolism of lidocaine and increased risk of toxicity. Also, low water solubility of local anesthetic usually limits the renal excretion of the parent compound to less than 5% of the injected dose. So that becomes significant in patients with severe renal failure. When you add a vasoconstrictor like epinephrine, like 5 mic per ml, to local anesthetics, for when you're doing infiltration or peripheral block or epidural spinal anesthesia, it produces local vasoconstriction. The vasoconstriction limits systemic absorption of the local anesthetic and prolongs the duration of action because the local anesthetic sticks around longer around the site of action. With decreased systemic absorption, we have a better chance of matching the metabolism to the rate of absorption and decrease the possibility of systemic toxicity. Epi may also decrease the likelihood of a systemic reaction by serving as a marker for detection of intravascular injection. Because especially in large volume, injecting epi in the blood causes tachycardia and maybe hypertension. But keep in mind that the systemic absorption of epi may contribute to cardiac dysrhythmias or accentuate systemic hypertension in the vulnerable patients. Also, epi should be avoided when performing peripheral nerve blocks in areas when the collateral blood flow is lacking, like the digital nerve blocks. In contrast, epinephrine-induced vasoconstriction can decrease local bleeding and may provide added benefit when combined with local anesthetic used for infiltration anesthesia.